Thanks, Ileana. Hi, everyone. I'm Dr. Jess Richardson. I'm a family medicine doc at UIH Mile Square Health Center, and I am one of the co-directors for behavioral health and addiction medicine with Nicole Gastala, and also the associate program director for the family medicine residency at UIC. And today we are going to talk about, my part is to talk about inpatient medicines for MOUD, and to give a little background about MOUD, so OUD itself, and then the medicines that we use for it for treatment. Go ahead, Nikki. I think one of the main things to really drive home and to get across is that OUD is a chronic medical condition. It is something that we should treat as a chronic medical condition, just as we do hypertension or diabetes. OUD, there are medications to treat OUD, and so we should really use them as a mainstay for our patients who are diagnosed with opiate use disorder. It's like saying, patients with diabetes, if we just treat them with a nutrition consult instead of treating them with insulin and pills for like glipizide or salt or whatever the GLP-1s. We would never not give a patient with diabetes insulin if they need it. We wouldn't just give them a nutrition consult. We would treat their whole chronic disease, and OUD should be very similar. When we treat patients with OUD with medications that are FDA approved for them, it decreases their illicit opiate use, it retains them in treatment, and overall it reduces their mortality from overdose. Go ahead, next slide. Patients who begin to use opiates, so heroin, initially when they use it, they're using it to reach that level of euphoria. And as their tolerance and dependence increases, they continue to use to reach a steady state of normal. So often patients will say, I've been using for X amount of years, and at this point, I'm not using to get high. I use so that I can participate in everyday life. I use so I can be normal. And what we're doing when we use opiate agonists to treat them for their OUD is we're helping them to maintain that normalcy. We're helping them so that they can participate in life. And participate in to be citizens in our world, in our social world, to fully participate while also treating their OUD simultaneously. Go ahead, next slide. The things that we are using for treatment really we're taking control of that mu receptor. So the mu receptor is what is bound by opioids like heroin or fentanyl. Heroin is a full agonist, so it binds completely to that receptor. Methadone is also a full agonist that binds completely, which is one of the FDA-approved medications that we'll discuss briefly. The other medications that we use, buprenorphine, is a partial agonist, so it will bind to that mu receptor, but it's not going to bind completely. And so when it doesn't bind completely, you don't get that euphoric type state. And the last one is naltrexone, which is actually naloxone, which is a mu receptor antagonist. So it will block that receptor from being bound by any opiates. And will therefore keep you from also receiving that euphoric state, but will not really so much treat any cravings or withdrawal symptoms. Next slide. So methadone, one of the FDA-approved medications for opiate use disorder, how exactly does it work? It is a full opioid agonist, so it will completely bind to that mu receptor. It reduces the euphoric effects of other full agonists, so like heroin or like fentanyl, but it does have a risk for toxicity, and it also has a risk for respiratory depression. So when we start this medicine, we have to slowly titrate it so we decrease the risk of causing toxicity with interaction with other drugs, because it is metabolized by that P450 system, so it does interact with lots of other drugs. And then also to decrease respiratory depression, especially in patients who have other comorbidities that already put them at a higher risk for respiratory depression, such as like having a concurrent benzodiazepine use disorder or having COPD, something that already decreases their respiratory reserve. Methadone in general has a high half-life. It kind of deposits in the adipose tissue and it releases slowly over time. And so it really can last up to 120 hours. So when we're initiating methadone and up titrating it, that's something to keep in mind, is that patients will have a very it's gonna take us a while to get to a steady state, and so we don't want to pile the methadone on top of each other rather quickly, because that will increase our risk of overdosing our patients or causing respiratory depression. So it's that's something that we have to keep in mind when we're up titrating them to achieve an effective dose to control their cravings and withdrawal symptoms. And if you're going to do methadone in an outpatient setting, it's only dispensed by licensed opioid treatment programs, so OTPs. So we can start it or we can continue it. So for maintenance and patients who are admitted to the hospital who are already on methadone, we can continue it on the inpatient setting. We could even begin it on the inpatient setting. But once they transition to the outpatient world, it has to be dispensed by an opioid treatment program. Go ahead and next slide. The second FDA-approved medication for MOUD is buprenorphine, plus or minus naloxone, which is Suboxone or Sublocade or Subzolve. This is a partial agonist of that mu receptor. It completes with the other opioids, and it actually blocks them from attaching. It has a higher affinity for that mu receptor than some of our full agonists. So that's why buprenorphine is such a wonderful drug, is because it binds partially to that mu receptor, but the affinity is higher, so it competes better for that receptor. Because it competes better, it displaces heroin and other opioids off of that receptor, so it knocks them off. So this is why when we're starting our patients on buprenorphine, we already want them in withdrawal, because we want those mu receptors to already be open, because if they're not, buprenorphine will take its place and then we will precipitate withdrawals in them, which is not a pleasant experience for our patients. But it is how this medication works in their bodies. The medicine itself lasts up to 24 hours, and it has because it has a prolonged therapeutic effect. It reduces the cause of overdose. So it is a wonderful drug for harm reduction. It really is protective to our patients and decreases their risk of overdose. Because it doesn't bind to that mu receptor completely, they are less likely to overdose on it. And because it has such a higher affinity for that mu receptor, if they are to use heroin on top of it, their risk of overdose is greatly, greatly decreased. So this is a wonderful medication to use to help with our patients to decrease their risk of overdose. Oh, sorry, and if it's formulated, I'm sorry, I missed that last part. If it's formulated with naloxone, it's helpful to help decrease the risk of abuse for this medication. So if naloxone is absorbed any other way besides sublingually, then it activates. So if a patient tries to inject, if they try to eject Suboxone, or if they try to get it down to where they can snort it, the naloxone will activate and it will block the opioid effects. Okay. Next slide now for real. Naltrexone is a full antagonist of that mu receptor. So we talked about methadone was the full agonist, buprenorphine was the partial agonist, and now we have the full antagonist of that mu receptor, and that's naltrexone. So it competes with the other opioids and it blocks their ability to bind to that receptor completely. It also will displace heroin or other opioids from that receptor. There is an extended release injection formula for this. So patients who are started on naltrexone, they can come in and get an injection, a sub-Q injection that will last an entire month. And it also is appealing as a non-opioid agent. There are no credentialing required for naltrexone, so you don't need a special waiver, you don't need any special training to give naltrexone. So it really is open to any prescribing provider can provide naltrexone for the use of opioid use disorder. And you can transition from the oral agent, from oral naltrexone to the extended release injection. Next slide. So with treatment, using these 3 FDA-approved medications, you see that we have increased retention in treatment for our patients who have opioid use disorder. We also have reduced illicit opioid use, which is going to reduce our risk of overdose because they have reduced illicit opioid use. The medications themselves that reduce risk of overdose death are buprenorphine and methadone. And because of that, because they're reducing use and they're reducing death, they also reduce all-cause mortality. Because you're reducing overdose death, you're also reducing complications secondary to opioid use disorder, like endocarditis or like cellulitis that becomes osteomyelitis. Patients who suffer from those complications secondary to the opioid use disorder, if we're correctly treating their opioid use disorder, we decrease their overall mortality. We also decrease their high-risk behaviors, and so then we reduce their risk of their HIV risk. Next slide. So you see, when we start patients on these medications, if we look at 12 months, those that are retained in treatment with reduced illicit drug use, for buprenorphine and methadone, we increase that by 60 to 90%. And if we just do behavioral therapy alone, we only retain them at about 6%. So we really should concentrate on treating our patients who have chronic opioid use disorder, to treat it as a chronic disease, to treat it with the medications that have been approved for it, and to treat our patients just as we would any other chronic disease, hypertension or diabetes. Next slide. Where can we get these patients? We really can hit them at any point within our medical system. They come in the ER, they come in the outpatient setting, they come in urgent care, they come in immediate care, and they come in when they get admitted. Whenever they hit our system, however they hit our system, and they come in contact with a prescribing provider, is where we should initiate treatment. Patients on average present to the ER about 6 to 9 times before they present for an overdose death. So we have 6 to 9 times on average of them getting to the ER that we have time to place, to put a footprint there and to say, hey, we recognize that we have identified you as having opioid use disorder, and we would like to begin treatment for you. We'd like to offer that to you. So it's a significant effect we have on our patients. They do enter our system often, and to recognize them and to begin treatment for them is essential. Next slide. So for methadone in general, this is based on the California Bridge Clinic. We can initiate methadone on any patient who we have diagnosed via DSM-5 that they have opioid use disorder, and they have been educated and they have been provided with the options for FDA-approved medications. As long as it is in a formulary at our hospital, you can initiate methadone while they are on inpatient. With this quick start, patients, unlike buprenorphine, patients do not need to be in withdrawal. And because we are closely monitoring them on an inpatient setting, we actually can rapidly up-titrate that medication. Like I said before, methadone has an increased risk of respiratory depression and toxicity when it comes in contact with other medications that are metabolized in that same route as methadone. So when we up-titrate them, if they're on the unit, if they're on the floor already, we can closely monitor them with the Ramsey scale to make sure that they're doing okay as we up-titrate them. And we can also see if we need to further control, like if their cravings and their withdrawal symptoms are properly controlled, and we can use the COWS score to help with the withdrawal symptoms. However, once you start a patient on methadone, the first thought should be, where am I going to connect them on the outside? Because they have to go to an OTP, an opioid treatment program for methadone. That has to be the first thought of, when I put this order in the computer to start methadone, I need to be taking the steps to link them to care. I think the other thing you want to keep in mind when you're initiating methadone is, because it takes so long to reach that steady state, because it has such a long half-life, you do not want to rapidly increase immediately prior to discharge. Because if that patient is not going to be seen in their OTP for 48 to 72 hours, you don't want that medicine to rack up in their blood system and increase their risk of overdose without being seen by another provider. So you want to hold off on any further increases about 2 days prior to discharge. Go ahead and next slide. I know I'm running out of time, Ileana. I'll try to go super, super faster. So buprenorphine, very similar. California Bridge Clinic can also help initiate buprenorphine on the floor. For buprenorphine, you do want to monitor via COW score because you want them to be in an appropriate level of withdrawal before you start that medication, or else you're going to have a very unhappy patient who has precipitated withdrawals. And then that's going to increase their risk of AMA so that they can go which is very acceptable to they want to go treat their withdrawal symptoms. And so they will leave AMA to go adequately treat their own withdrawal symptoms. And that is something that is of concern. So we definitely, you want to, before you initiate buprenorphine on the floor, as long as it's on formulary, there is no reason not to initiate this one as well. If the patient so chooses it, they would like that to be their treatment of choice. Next slide. The longer we keep patients in treatment, the better. The longer they are in treatment, the better outcomes for both methadone and buprenorphine. There are no contraindications. This is a chronic disease. It is a lifelong disease. We do not want to quickly take patients off of opiates and then bring them back outside. Just like we do not want to start patients on insulin just for 6 months and say, oh, in 6 months we'll take you off, you'll be fine. You should know how to eat by then. You should know how to eat a diabetic diet by then, you'll be okay. The same thing for this. Opioid use disorder is a lifelong disorder, and thus we should treat it as long as a patient is requesting treatment. The road of addiction is a long, winding road, and therefore we should treat patients where they are. There's limited data for the duration of naltrexone, but again, as long as a patient is benefiting, there's no contraindication to stopping it. Go ahead. So that is it. Ileana, if there are any questions I can answer, otherwise we can go ahead. I think I'm at time.
Yes, thank you so much, Jess. Or Dr. Richardson, I'm used to working with you closely, so I can be very informal at times. I apologize. Dr. Richardson, thank you so much. That was great. If anyone has any questions, please feel free to put them in the chat. I know we have a lot to get to today, so because I don't see any at this time, I'm going to go ahead and introduce Dr. Ben Price. He's going to be talking to us about his work in medical stabilization and sharing his knowledge of best practices with us. So thank you, Dr. Price, for being here, and I will let you take the mic.
Sure. Thank you, Ileana. Good afternoon, everyone. My name is Ben Price. I'm a family physician at Lawndale Christian Health Center, where I have the privilege of working with our amazing team in substance use treatment services. And as part of that work, we provide the clinical care at the Medical Stabilization Unit at St. Anthony Hospital, which is one of our closest partner hospitals right down the street here on the west side of Chicago. So I'm going to be focusing specifically on MSU, or Medical Stabilization Unit best practices, and again, specifically to our OUD population. Though we care for patients with alcohol use disorder and other substance use disorders in the MSU, we're really just focusing on OUD today. This is briefly what we'll hit. I'll touch on what is an MSU, because I think there's some misconceptions about what it is and what we do. I'll try to highlight just 2 best practices and then interweave those best practices into what the goals or objectives as defined by our national guidelines should be of any MSU. And then I'll just throw in 2 quick points for you all to consider in regards to our work in MSU. And let the record state that I have no conflicts of interest in this activity as well. So we can go ahead and jump in. What is an MSU? Actually, let me jump to the bottom and start with what is it not, okay? Let's just start with the D word, detox. So let's be honest, I use that word, our patients use that word. Probably everyone on this call has used it or has referred to it in the past. But I want to be very clear that a medical stabilization unit is not a detox unit. That is not what we do, nor what we should be doing. And we'll get into a little more detail on that in just a sec. We are also not an acute medical, surgical, or psychiatric unit. Okay, so if a patient has a diagnosis that with an acuity that warrants admission to the hospital for a medical, surgical, or psychiatric reason, they should be admitted to those respective beds and be cared for those co-occurring OUD. So Dr. Richardson just laid that out. There's no reason we can't address OUD in the ER, as Dr. Holford's going to talk about, or in our inpatient beds. But specifically in the MSU, we'll talk about how we manage OUD. And then lastly, we're going to talk a little bit about the continuum of care for substance use disorder. And just to be clear, the MSU is not treatment in itself, okay? It is one slice of a continuum of care for opioid use disorder. And patients don't need to just go to detox and then call it a day. It is one slice in a continuum of care that is required for ongoing care of a chronic disease, as Dr. Richardson laid out for us. So what is it though? So an MSU is a hospital-based inpatient unit. The American Society of Addiction Medicine, or ASAM, would qualify this as level 4 treatment. And in other words, it's a medical bed. And it comes with all the bells and whistles of a hospital bed. It has all the resources, whether it's the diagnostics or consultants that are available to patients, or the 24-hour medical and nursing care. All of those things are part of a medical stabilization unit. The unique nature of it is that patients are being admitted for a primary diagnosis of opioid use disorder in this case. And so we'll go to the next slide, if you don't mind. When we think about which patients then are being admitted to an ASAM, to an MSU, if you look at the illustrations here, essentially we're talking about patients who have a severity of their OUD that warrants inpatient admission. So on the far end of that continuum of care, level 4 is an MSU. And when we think about placement criteria for patients that need OUD treatment, those patients, particularly with complexity or severity in dimensions 1 and 2 of ASAM criteria, so that's those who are at have an acuity or severity of intoxication or risk of withdrawal, as well as biomedical complexity. And it's usually a combination of those two things that really warrants 24-hour medical and nursing care to stabilize patients from their opioid use disorder. Next slide. So that's what an MSU is. I think we can kind of summarize best practices in an MSU to kind of 2 themes, and then we'll introduce these 2 themes into the goals of an MSU. So the first is evidence-based medicine. This is not a revolutionary idea, but believe it or not, I think historically detox units or medical stabilization units have not always been evidence-based. And so I want to put that out there. First and foremost, every MSU should be evidence-based. And in doing so, we should individualize our patient care. Patients that come in for heart failure to the hospital are not treated universally with one-size-fits-all protocols, right? We have patients with an ejection fraction of 10%, we have ejection fraction of 50%. Right heart failure, left heart failure. We address these patients individually, and so we should be doing the same in MSU. We should not have one-size-fits-all protocols and order sets. We should be tailoring our approach in the MSU, and then in terms of our linkage to care into each individual patient. And in doing so, respecting their autonomy, truly giving them informed consent so they understand at a level that they the risks and benefits of stabilizing on medication versus perhaps medically supervised withdrawal. And also they understand between buprenorphine and methadone. These are really important conversations that need to be individualized to each patient. And then the last thing is, a lot of us have been patients in the hospital. We work in the hospital, we've had loved ones in the hospital. At this level of care, this acuity, it is often a unique time in a patient's life. And so I wholeheartedly, I know this is on the softer end of medicine, I wholeheartedly though believe that addressing stigma and offering hope and encouragement, while we should be doing that at every step along the continuum of care, the MSU really presents a unique opportunity to do that for patients struggling with OUD. And so we should be doing that and individualizing that particular message for all of our patients as well. Next slide. So if you take away any, it's these next couple slides. When we talk about evidence-based medicine, I haven't read much, but I'm going to read this. This is from the treatment improvement protocol from SAMHSA, medically supervised withdrawal, aka detoxification. Studies show that most patients with OUD who undergo medically supervised withdrawal will start using opioids again and will not continue in recommended care. Next slide. These are some of the, go ahead, next slide, thank you. There we go. These are some of the studies that, show this to be the case. I would say best case scenario, what you see here is that detox or medically supervised withdrawal is ineffective. At a worst case scenario, I would say it's actually harmful. We're setting patients up for overdose and putting them at higher risk of mortality from that overdose by decreasing their tolerance and ultimately returning them to the community. And so I know first day of medical school, we recite the Hippocratic Oath, do no harm, right? I would say if we are not truly offering informed consent and informing patients the risks of medically supervised withdrawal and detox, then we are not doing our jobs practicing evidence-based medicine in a medical stabilization unit. Next slide. And so not only should we not be detoxing or providing medically supervised withdrawal, the national practice guidelines from ASAM say that this is not recommended, but rather ongoing maintenance medication in combination with psychosocial treatment appropriate for the patient's needs is the standard of care for treating opioid use disorder. So again, this is standard of care. We are not doing anything other than trying to provide a standard of care as we would for any other condition in the hospital or outpatient for that matter. Next slide. There we go. So for the goals or objectives of the MSU laid out by SAMHSA and ASAM, this is essentially their three objectives. The first is to evaluate patients' OUD, in this case, in co-occurring conditions, to care for them till they've reached a clinically stable state. So that's really addressing their withdrawal. And then perhaps most importantly, to connect them to ongoing care in that continuum of care for OUD. So in each of these, we'll run through them briefly now, but I think in each of these, if we incorporate those two best practices of making sure it's evidence-based and that it's individualized for each patient, I think then you can say that your MSU is performing at a best practice level. The next slide. So when we evaluate a patient's OUD, I think historically there's been detox or medical stabilization units that would do something like, would you like methadone or Suboxone? And that was sort of the extent of evaluating the severity or the history of the patient's OUD. I think it's really important that we're getting into it both for the immediate care that they're going to receive in the MSU, but also how it might influence recommendations for linkage to care. So really spending time taking a thorough history with the patient, performing a physical. A lot of patients are presenting to the MSU as their only, and I'm sure we'll hear from Dr. Like in the ER, this might be their only interaction with the healthcare setting, unfortunately. And so we often identify chronic disease or other acute conditions such as infections or a new heart murmur concerning for an endocarditis or something like that. It's very important that we're doing a thorough H&P and using an evidence-based tool like CalScore to guide our initiation of buprenorphine or other medications. In terms of diagnostics and labs, I won't go into too much detail. This is typically a high-risk population. We should take advantage of our time with them to screen for HIV and Hep C, make sure their liver is still working. In terms of UTOX, I think the important thing here, methadone can really steer your ability to treat with either bup or methadone, or the timing of. And if you do, in your talks, making sure that you discuss with the patient whether it's a contaminant or they've actually been taking methadone from the community or from another OTP. I won't say too much about fentanyl testing other than to be very clear. If you have a negative heroin screen on your urine, but you have a clinical diagnosis of OUD and at risk of withdrawal, you 100% can and should be admitted to the MSU if that's your intention. You do not need a positive heroin or morphine screen in your urine for that. Screening for, and it's because so much of the heroin, at least here on the west side right now, is fentanyl, and that may not show up in the immediate point of care urine drug screen. Testing for fentanyl can be helpful in how we change our culture and counsel our patients and sort of build a greater awareness of what's going on in the community. So I don't necessarily discourage it, but I think it's really important we understand you do not need a positive tox to be admitted to an MSU. Next slide. And so this is really, why patients are coming in though, right? So they want to reach a clinically stable and supported state, meaning they want to be, they want their withdrawal symptoms to be stabilized and cared for so that they can continue in their treatment plan or their treatment goals. Buprenorphine or methadone can safely and effectively treat withdrawal symptoms. They have very similar efficacy. And that's both when we talk about symptom management as well as retention or linkage to care. They both have very similar numbers in regards to both of those things. I think there's a number of considerations for buprenorphine as a first line treatment. Some of them are more practical, for instance, length of stay, residential treatment options. Dr. Richardson touched on a number of some of the more clinical rationale for using bup as a first line treatment, including the fewer drug-drug interactions, the overall safety profile in terms of treating withdrawal symptoms and the ceiling effect, and the ability and the half-life and how that affects our ability to perhaps dose more frequently to address a patient's symptoms. However, this cannot be overstated. It's a really important and nuanced, individualized conversation. We can't walk into patients' rooms and just say, hey, what do you want, bup or methadone? We have to pull up a chair and talk to them about their experiences with buprenorphine. If we're honest, many of them have tried it in the community and have had poor experiences, perhaps precipitated withdrawal. And so it's important you sit down and explain why that might have happened and what we're going to do here in the MSU to ensure that that doesn't happen. And likewise, explaining sort of the benefits of methadone, particularly stabilization on methadone as well. So these are important conversations that we can't be having in 20 seconds over the phone, or that we should expect our nurses to have, at midnight. Next slide. I won't go into too much detail about this. This is on the left, you see an illustration about how we administer bup. On the right, it's methadone. It's essentially the same that Dr. Richardson just laid out. I think depending on their withdrawal score, we start with 4 to 8 milligrams of bup, and we titrate that up to a goal of 16 to 24 milligrams daily, and continue to prescribe 4 milligrams, Q4 hours as needed for withdrawal symptoms. For methadone, again, we found that 30 to 40 milligrams often is not enough to effectively manage withdrawal symptoms for patients with more severe OUD. And so titrating to 50 or even to a max of 60 milligrams on day 3 is our protocol. Next slide. Adjunct medications can be your best friend in terms of buying time or addressing withdrawal symptoms as you are starting either of those two medications. And so really educating your nurse team and the patients about the address some of your more targeted withdrawal symptoms can be truly game-changing for patients. And so these are what I would call an adjunct medications toolkit. There's a wonderful chart actually in UpToDate that lists these by symptom and is a good reference if anyone's looking for an adjunct medication toolkit illustration. Next slide. And then the last, perhaps most important piece of any MSU when we talk about best practices is linkage to care. So we're over there at ASAM level 4 and making sure they get connected somewhere along that continuum of care. And again, every patient is going to be different. So whether that's transitioning to a 28-day program, to recovery housing, to an IOP, to outpatient services, any of those may be appropriate for a patient. And so individualizing that conversation and connecting them to the setting that would be most effective for their OUD and for everything else that's going in their life is critical. And then I will just make a plug. I think we can do better, at St. Anthony, but I think across the board at MSUs in providing a higher level of counseling and harm reduction education for patients while they're there. And that would include making sure that every patient that is discharged with Narcan in hand, not a prescription, but in hand, especially, I should say, not even, but especially for those patients that leave AMA. And again, I made a plug. I do think there's something special that can happen in the MSU in terms of relationship building across the system and trying to reestablish trust that, historically has not been there. In our system and addressing the stigma of OUD. It can take time, and so the MSU can be a really special place for that. Next slide. 2 quick plugs real quick. Partner with your MSU. If you don't know where your community MSU is, feel free to email me. I could probably give you an idea. The super website list, super website I believe has a list of them as well. Partner with your community MSU, both as a resource for you in your work, but also so that they know what you're doing and can utilize your resources as well in terms of linkage to care. And then in doing so, communicate in that communication. Make sure you're advocating for best practices in evidence-based medicine. Make sure they are not doing rapid detox. Make sure they are not switching patients that are preferential or stable or even desiring to be on buprenorphine over to methadone. Make sure they are providing evidence-based best practice approaches to care. And I think that's all I have. There's my email. So like I said, please feel free to email me if there's any questions or if I can help at all.
Wonderful. Thank you so much, Dr. Price. That was great. Please, if folks have questions, feel free to drop them in the chat. We may have some time at the end. I want to make sure that we have time to get to Dr. Holtzford. And of course, you can reach out to Dr. Price by reaching out to him using his contact information. I also think Dr. Gustala has joined us. Dr. Gustala, are you with us?
Yeah, one quick thing that I wanted to say, thank you so much, Ben. I think your presentation and Dr. Richardson's really highlights what is evidence-based practice for patients with opioid use disorder within the hospital systems, right? And one of the important questions that we get from hospitals who have historically housed these withdrawal units or detox units is that, well, we're not going to get paid if we do not, titrate someone down. So, and that's not true. So detox makes sense that, word withdrawal and medical stabilization, withdrawal management makes sense for patients with alcohol use disorder, right? The reality is that the evidence for opioid use disorder is that you do not detoxify them, that you actually induct or start and then maintain them and stabilize them. So you will get paid by the insurance companies for stabilization. That's not, they're not mutually exclusive where you have to taper someone off in order to be able to get reimbursement for that. So that's really important to share with your community hospitals who may be working or practicing and in a sense under this guidance that they must detoxify a patient in order to get meet criteria for reimbursement. That is in fact not true for opioid use disorder. So please share these guidelines, encourage them to incorporate these evidence-based practices for opioid use disorder as part of their care model within these units.
Thank you so much, Dr. Gostala. It's a critical point to emphasize. All right, Nikki, I think we can go to the next slide. And Dr. Holtzford, you're up. Thanks so much for being with us today.
All right, thank you. Thank you, everybody. Yeah, my name is Steve Holtzford. I'm an ER doctor out at Del Nor in Geneva, but I'm actually in the process of sort of shifting gears over to addiction medicine. I took the addiction boards a few years ago and found it to be just incredibly fulfilling work. So now I'm just part-time in the ER, primarily doing addiction. I'm the medical director of a residential facility here in St. Charles, RCA, medical director of Lighthouse Recovery, which is a small clinic in St. Charles. And I go to the Kane County Jail every Tuesday to provide buprenorphine for the inmates with opioid use disorder. And I also do some opioid use disorder treatment through telemedicine, which is actually very exciting, especially in this COVID world. And I have patients, all over the state of Illinois where they would normally not be able to get care. So if anybody has any questions about how to sort of jump into this work as a kind of a second career or something extra, kind of tired of the ER, I am your go-to. And I will put my email in the chat as I finish. Next slide, please, Nikki. So emergency department buprenorphine is here. We all need to be doing it. Every ER in the state needs to be capable of starting patients on buprenorphine. It really is quickly becoming the standard of care. The evidence is overwhelming, and this is really the landmark study which told us that we can do this and it works. This is now 6 years old, this study. It's from JAMA, from the group at Yale. Yale has done a lot of work in this area, continues to. But in this landmark study, 2015, they divided about almost 400 patients into 3 different groups. They were all in the emergency department with severe opioid use disorder, either complication of use, non-fatal overdose, infection, withdrawal, those types of symptoms. Randomized to 3 groups. One, basically just given a referral. That's kind of what sort of the baseline is in emergency department care at this juncture. Group number 2 was they would get a brief interview, sort of a motivational interview plus referral to treatment. And then group number 3 added buprenorphine to the mix. And what they found is that the group that received buprenorphine was engaged in treatment at 30 days. 80% of them were engaged in treatment, which was more than twice as high as any other group. And I should actually note that the other groups did pretty well too, much better than they would at my hospital or most hospitals. Right? I like to say, well, it was a kind of a Yale interview. It was a Yale referral. They checked insurance and so forth. So, but even so, 80% were still engaged in treatment at 30 days, which is really remarkable. So this was the sort of the jumping off point that, hey, this works, let's do it. All right, next slide. So this is from 2019. This is from one of our ER journals or one of our throwaway papers. the final word on buprenorphine, start it in the ED. Again, there's no, if you run into an ER doctor or an ER director that says, oh no, that's really not the role of the ER, you know, substance use disorder, that's an outpatient thing. We're in the ER. We're just here to you know, save heart attacks and so forth. You need to correct them. Give them my name. It is absolutely not accurate. We need to be starting buprenorphine in the ED and discharging patients on buprenorphine. It is quickly the standard of care. If I had more time, I could talk about the data, but the chance of death after a non-fatal overdose, after someone's discharged from the ER, is very high. It's very high. It's 5% at 1 year, 10% at 2 years, extremely high in the first 30 days after discharge. It's a really compelling, tragic data. Next slide, Nikki. So what to do? This is also from 2019. So this article is 2 years old now. And so Dr. Oury and Dr. Adams, Dr. Oury is from the CDC, and Dr. Jerome Adams, as you know, is probably a Surgeon General from the prior administration. So this is from the Annals of Emergency Medicine, which was basically a plea to the emergency medicine community that said, please help us. And they go into, we're doing pretty well in some areas. I think that the American College of Emergency Physicians has done some outstanding work, and they call that out. But in general, the uptake of emergency departments doing this work has been too slow. It has been too slow. So we need to get going on the buprenorphine in every ED in the country. I live in Illinois, so that's going to be my focus. Every ER in Illinois needs to be capable of prescribing buprenorphine, and these patients leave the department with buprenorphine and with naloxone in their hand. Next slide, please, Nikki. So here, this is hot off the press. This just came. This is not even in the journal yet. It's available online. This is from the American College of Emergency Physicians. They just came out with the consensus recommendations on the treatment of opioid use disorder. And as you will not be surprised, it basically says, do it, do it, do it. It's not hard. These patients need it. There's a huge treatment gap. We are able to intervene. It saves lives. In the emergency department, we do things that are so much harder than starting buprenorphine. You know, strokes, you have to get the CT scan in 30 minutes. Heart attacks, you have to read the EKG within 10 minutes. Sepsis, you have to start the antibiotics within 3 hours. You have to get the fluids in. All these measures. And with a morbid disease like opioid use disorder, we don't have anything. There's no metrics. You know, you can basically, all you need to do is have a process to get this valuable life-saving medication in the patient. Get them in the patient. When they're on buprenorphine, those mu receptors are blocked. The high affinity keeps a full agonist from attaching and protects from overdose. So we need to be doing this. All right, next. So here there are different algorithms. Dr. Richardson showed one very similar to this. This is the Yale protocol. Again, it's easy. You wait until they're in some withdrawal, so there are empty mu receptors for the buprenorphine to attach to. It's preferable not to give buprenorphine too early, because then it'll kick out a full agonist and precipitate withdrawal. Not that precipitate withdrawal is horribly dangerous, but you want the patient to feel better. Again, as was mentioned, you know, these patients have a difficult experience with healthcare anyway. You want your medicine to make them feel better. So this is an easy algorithm. This is the one that we use at our hospital. I don't have time to go through it in detail, but available online. All right, next. And this is California Bridge. We've seen this in Dr. Price's presentation. Again, California Bridge. These Yale, California Bridge, other organizations have really done a wonderful job of giving materials freely, and they've been validated. They work. There's no reason to reinvent the wheel. Any emergency department that wants to do this work, there are resources out there to get this work done, and I am more than happy to help. Okay, next. Here is, say the patient's not in enough withdrawal. They just used 2 hours ago. They're not going to be in enough withdrawal for 6 or 8 more hours. There is a home induction instructions that is perfectly validated, perfectly safe. This medication is very safe. These patients can read. They know how to take medication. As Dr. Price mentioned, most of these patients have experience with buprenorphine, so giving them directions with a script for buprenorphine is perfectly reasonable. Next. There we go. So quickly, ED buprenorphine, it's easy. It is so much easier than many things we do in the ER. Super safe, super safe. There's very little drug-drug interaction, incredibly effective. Mortality decreased by 50, 60, 70% in these patients, saves lives. And the ED, every ED needs to be an entry point to treatment. This is where these patients end up 24/7. Overdoses, complications of injection drug use, and withdrawal. They end up in our emergency department, and the emergency department really, we relish sort of being the safety net of our communities, and this should be no different. Increases patient and staff satisfaction. Absolutely. The patients feel better, they feel better quickly. The staff will love you for prescribing buprenorphine and giving buprenorphine in the emergency department, because these patients are miserable, they feel bad, they're throwing up. You don't need an IV. You know, if they're a hard stick, you don't need labs. You just need to saturate those mu receptors with a partial agonist. That's what they need. They are deficient in dopamine. They need dopamine to feel better. Decreased length of stay, that's been shown. Of course, everybody loves decreasing length of stay in the ER. If you have quality people in your institution, they will love the fact that you're increasing satisfaction and decreasing length of stay. Decreasing stigma. This happens. It doesn't happen overnight, but once you start a program where you're giving buprenorphine, you will see your ER department change. The nurses will start to look at the patients differently. When they learn a little bit about the pharmacology and the neurobiology of addiction, your whole department will start to look differently at these patients, and that is what we want. We want the stigma of this disease to be decreased, so patients in your community feel welcome in the emergency department, not horribly stigmatized. And I feel badly. I mean, 10 years ago, you wouldn't believe what I used to say about these patients, and now they're my favorite patients. So every ER really needs to embrace this concept of decreased stigma. And I think that might be all I have.
Yes, thank you so much, Dr. Holtzford. I know we're almost right at time. I would just want to thank quickly the presenters. You all did a fabulous job. Thank you for sharing your experiences. Thank you for the work that you do day in and day out. And thank you for your honesty and your sincerity in sharing this good work. We did have one question. I know Dr. Huggett was asking if one of you could just comment on his question very quickly. It says, could the presenters comment on the use of microdosing and initiation to avoid precipitating withdrawal, especially with those who have had that adverse experience? Does someone want to give a quick response?
Yeah, I think that this is a great tool that we have started really including within our inductions for patients, especially for those who are on fentanyl or have had a history of not tolerating the withdrawal period or perhaps precipitating withdrawal. For some reason, fentanyl sticks around on the receptors a lot longer than we anticipate. And there's some really interesting studies in terms of how long it'll still be in the urine, actually. So there is no exact standardized protocol yet for that, but there are different case studies that have proposed different ones. And I have to say that there's a difference if you're transitioning someone from methadone or street methadone to buprenorphine, you have to do very low microdosing for much longer before you titrate up versus fentanyl or other short-acting opioids. But microdosing is an extremely effective tool, and something that we will definitely send out resources to the whole group with the different sort of models that you can use. But there is no sort of one standardized approach yet, just different sort of case studies that have tried it.
Thank you so much, Dr. Gostala. So that wraps up our webinar for today. I know we have an evaluation. You can actually use this QR code. You'll have 2 weeks to complete it. We'll also send it out in an email. And that will include, you'll get slides from today, as well as some handouts for reference materials. And just keep in mind, if you haven't yet registered, we have 2 more webinars coming up in this series, including a special presentation next Friday over the lunch hour that will feature some of the presenters you saw today, in addition to a few others. It will be a super quick training on the new changes to the federal regulations around prescribing buprenorphine. So you don't want to miss it. Spread the word, register right away. All of these trainings are free. Thank you all for your time. Have a lovely weekend. We hope to see you again soon.